second webinar for the Older Adult Mental Health Interventions course. We're going to just kind of start a little slowly to give a few more people a chance to join in. But Darcy, did you want to share a few kind of housekeeping pieces of information?
Yeah, absolutely. Everybody, hi. This is Darcy McGaffick with CIMH. And I'm the organizer for the webinar today, which means I'm mostly going to be behind the scenes just sort of doing a few like logistical things. But I was just going to talk for the next just couple minutes or so about a couple of things that will be happening during the webinar. Some of you were at the last one. A lot of you were, I think. But just in case, we're going to go through just a couple things about the technical things, one of which is the audio. Right now, when you join the webinar, you are automatically by default muted. So right now, you cannot speak into the webinar. We will be trying to kind of incorporate people into the webinar a lot more than we did last time. Last time we were just kind of figuring out the technical issues, and this time Dr. Yang has as a major priority bringing people into the discussion on mic, as well as recognizing their questions. If you would prefer not to talk on mic, of course, we can always take your questions in the question box. So the first thing that I should let you know is that Dr. Yang has built into the presentation a number of places where she's inviting comments and questions. And at that point, I'll be looking to see if people have put up their virtual hands, which is there's a little box that you can see. There's a hand that you can click on your control panel. The control panel is the series of boxes that you have that run down probably the right-hand side of your computer. And you can click on that one time, and it raises your hand. If you click on it another time, then what it will do is drop your hand back down. So what we were hoping to do is a quick test just at the top of this session to make sure that you can find that hand and that you can raise it and make your comment when the time comes. So if I can ask everybody, if you can hear me, to go ahead and click that hand button. I see April clicked hers. Go ahead and click your hand button one time. There goes Anna. And I see Bill. A number of people. Them to speak? And let's see, if you do not want to talk at this point, go ahead and drop your hand down. But if you wouldn't mind just saying, hey, test, 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 leave your hand up, and I'm going to come to you and undo your mic. Let's see, Bill Brennerman, I think I'm going to come to you if possible. I'm going to unmute your mic. And in a second, you should be able to talk into the webinar. Bill, can you go ahead and say hi? Now, here's one thing. For you to have signed on through your computer, you have to have a mic attached that you can actually talk into. If you've signed on using the computer option and you don't have
muted.
That was interesting. So I was muted for a second there. If you've signed on using the computer and you don't have a mic, then probably what you're going to want to do is go to your audio box on your control panel and switch over to the use telephone mode. And at that point, what you'll do is you will sign in you'll dial in on your telephone using the phone number that's listed right under the audio information. You're going to click that plus sign in your audio box. You're going to click use telephone as your option, and then you'll use a phone and you'll dial into the telephone number and the access code, and that will make you able to talk on the phone. I'm not sure if that's what the problem is, Bill, but I wasn't able to hear you. If someone else can go ahead and hold up a hand, I'm going to go ahead and come to you and see if we can unmute you. Okay, let's see. I'm seeing some hands, but not phone people with phone numbers. When you have gone ahead and signed in, you have the opportunity to enter an audio pin. For instance, let's see. Christy Duggar, I'm going to go ahead and try and call on you. Christy, can you talk in? April Waldo, can you talk?
Yep, can you hear me?
Hi, April. Yes, I can.
Hi,
Yay.
April.
Yay. Okay. What I'm seeing is that if you've signed into the webinar using the telephone option, oh, there's Bill. I'm going to unmute you, Bill Tornquist. There you go, Bill.
I'm here.
Hi, Bill. So I've got
Hi.
April and Bill. April, I'm going to mute you back up again, and let's see. Brian, if you have a Brian Nance, if you have a microphone on your computer, we should be able to hear you. Brian, can you talk? Okay. This might be a situation where somebody, and I don't know this for a fact, Brian, this might just be something strange, but if you've signed on using your computer and you don't have a microphone, you should go ahead and go to that audio box, and you're going to want to click the plus sign and use the telephone option, and then use that information that drops down in that box to call in on the phone. Sorry this is taking a little while, you guys. We're still kind of working out the kinks. Christy Duggar, I'm going to go ahead and unmute you if you don't mind. Say hi, Christy.
Hi, this is Christine.
Oh, there we go. Perfect. Lovely. That's working great. I'm going to close your mic back up, and then we're going to move on in a second or two. At that point, what I'll ask everybody to do is feel free to write into, oh, Joanne, I'm going to do a quick test of yours. Joanne Ruggiero. Sorry, I ruined your last name there. Joanne?
That's good. We're here.
Hi. Okay. Oh, there's a few of you over there.
Yes.
Ah, all right. How many?
We have 8.
Awesome. Hi, everybody. I heard everybody saying hi back. I'm going to mute you again, Joanne. Okay, so now moving on from that situation, if you have any problems with audio, and I know that is our stickiest area, what I'm going to ask you to do is just go ahead and type into the question box. We have a question box that's a little lower on your control panel. You can click that plus sign on that, and that gives you the opportunity to go ahead and type in any type of question that you might have. Oh, I see somebody already typed some stuff. Oh, there we go. There are some people who have already typed in like the word test and things like that. So that's great. I see what you're doing there. I don't have a mic calling in Leslie. Very good. Thank you. Excellent. All right. So the second thing that, well, we talked about the audio options, the easiest of which appears to be the telephone. We talked about raising hands and also the question box. And now the protocol with questions. Dr. Yang has built in these periods of time when she will be soliciting comments and questions, but of course you can ask a question at any point. Probably the best way to do that would be to type it into the question box, and I'll be monitoring that, and I might type back to you, do you want to talk about this on mic? If you don't want to ever, just let me know. I won't call on you if that's the case. And then the other thing is, the last thing that I can think of is we've built, last time you were really kind about filling out the evaluations that we sent to you. Thank you for that. This time we've built just a few little questions into the webinar program that you have the opportunity to answer on your way out. It's just 7 or 8 questions. They're very brief. 5 of them I think are just rate on a scale of 1 to 5 type questions, you know, your ability to answer the learning objectives, yada, yada. And then the last thing is just what did you like, what didn't you like, what would you suggest for future stuff. So that will hopefully come up at the end. Anyway, Dr. Yang, I'm so sorry to have taken so long, but hopefully...
we need to work these things out, yeah.
Yeah, hopefully we can move on nicely from here. I'm always available. If someone didn't get materials, please type into the questions box and I will email them to you immediately. If you're having any problems, same thing. And now I'm going to go ahead and mute myself and turn this over to Dr. Yang. Thank you very much, everybody.
Darcy, thank you for handling these technological issues, which I am pretty difficult for me. I just had a couple other introductory thoughts. Again, thank you for your evaluations and your comments. We are reading them and trying to respond to what we can. And I know many of you are interested in continuing education. And just so you know, because this is a webinar, it's a little more new to us to be, and CIMH to be figuring out how to get the CEs approved. We still do expect that to happen, but unfortunately it's not quite final yet. And we're also still working on how we archive the presentation. So we're still working on those two things. And then a third thing, we got some feedback that some of you had tried calling in and got a busy signal. If that happens again, if you could let us know by email, we'll look into that with the webinar. There should be room for 1,000 people to call in, so you shouldn't get a busy signal. But if that does happen, if you let us know, we'll see what we can do to figure out what the problem is. So for those of you that are new, I'm Janet Anderson Yang, and I'm sitting in Pasadena in my office. I'm the clinical director of Heritage Clinic, which works in Los Angeles and San Diego counties, and I'm working also as a consultant to the California Institute of Mental Health. And this is our second webinar out of a series of 8. And so for today, we're going to be talking about field-based issues, including outreach and engagement, safety issues, and boundary challenges in the field. And I just want to let you know, I've prepared a lot of material, which is probably more than we can get through in the 2 hours. But I just want to let you know, there are some slides that I put into the slideshow just so you'll have them, but we may not talk about all of them. So hopefully that won't be frustrating for you, but it just hopefully will be a little bit of extra information. We are, as I mentioned 2 weeks ago, we have been given the opportunity to do 8 webinars and asked to cover way more than 16 hours worth of material. So I'm trying to balance going fast, which I know can be irritating sometimes, with getting as much information out. So these are the learning objectives. I am hoping these are some of the things you'll learn in addition to other things, but I'm hoping that you'll be able to list at least 5 gatekeepers with whom you could facilitate relationships to develop further outreach strategies. I'm hoping that you'll be able to describe 1 to 2 approaches to engage a reluctant or ambivalent, or the word we don't like but used to word resistant, kind of older adult client in a treatment relationship. And I'm hoping that you'll be able to label at least 2 to 3 boundary challenges that occur when we're doing mental health interventions in the field, and 3 to 4 approaches that could help you navigate those boundary challenges. So first of all, we have a poll. We asked a little bit last week where you all were in the state, and today we wanted to find out whether you work for an agency that's primarily mental health, or whether you work for an agency that's not directly mental health, but other kinds of older adult interventions, or perhaps a third type of agency. So Darcy, do you have a poll for us?
There you go. They should. Everybody should be able to vote at this point. I see a lot of people already voting. Yep. Great.
Okay. So we'll give you a chance to tell us what kind of work you do, what kind of agency you work for. Just so you know that we have targeted for this webinar series folks that generally work with mentally ill older adults, which could include working for a mental health agency, or could include working for a partner agency who works with older adults who are also mentally ill. So it looks like what we have is about half of you are, 51% of you work for a mental health agency, 40% work for primarily an older adult agency, and 9% other. Okay, thank you. Then,
okay, thank you.
Yeah. Then another question, just to get an idea, and you'll have to make your own decision about whether you're in a large county. I'm in Los Angeles County. My answer would be obvious, a large county, but just to get an idea if you're kind of working in a smaller, more rural county, or a medium-sized county, or a large county. So if you could just make your best guess as to how you would answer that, that would be informative. And one of the things I'm happy about this webinar is that it can reach to people who may be out in more rural or farther flung areas, who wouldn't be able to access this kind of information as easily as, say, if you're in a larger, more metropolitan area. So the poll looks like about 46% work in what we're calling a large county, about a third in a medium-sized county, and about 20% in a small county. Okay, great, thank you. So the outline today, I'm going to talk about community outreach, which includes eliciting referrals and making contact with the older adult client. Clinical engagement, which I'm going to be talking about developing working alliances or working relationships with clients. Safety issues in the field, addressing boundary issues when working in the field. And then we may have a case presentation depending on, we had a participant that offered to present a case, but then she wasn't sure she was going to be able to get permission to present the case. So when we get there, we'll find out. If you're on the webinar, maybe you could type in and let Darcy know whether or not you're going to be able to present the case. So starting out, why do we do outreach and engagement? I mean, that's a big part of our FSP and FCCS and our other Mental Health Services Act programs and all of our DMH programs. But why is it that we need it, especially with older adults? So a number of reasons that we need to do outreach and engagement. Why is it that older adult clients, and some clients of various ages, but in our case older adults, why don't they just come and ask us for mental health help? We know they need it, or we suspect they may need it. So there are a variety of barriers that get in the way of them just coming for help. Some of them are emotional. Many of our older adults who could use services that are not yet our clients are afraid. They may have other kinds of emotional issues that get in the way of their coming, but I think fear is one of the big ones for older adults. Fear of being stigmatized, fear of being institutionalized, fear of being hurt, fear related to some of the issues or belief systems that they had growing up. And then on a more cognitive or attitudinal level, some of their beliefs may get in the way, that they feel that they think that it is stigmatizing, or they think that it means they're weak, or it thinks that they means that they're bad or sinful or shameful if they need or want mental health services. Then a big one for our population is physical. The barrier is just physically, they can't just come into our setting very easily, whether they can't drive or they can't take public transportation because of their physical illnesses. Financial can get in the way, depending on whether they can pay their share of cost or whether they qualify for Medi-Cal or whether they're undocumented and don't have any ability to pay financially. Then we have linguistic and cultural barriers. Linguistic, just not being able to find a provider that speaks their language. And again, that's more often, I think more often with older adults who may come here later in life and don't have the interest in learning the English here. And then other cultural barriers in terms of cultural beliefs of different cultural groups about mental health services, meaning it's shameful to the family or it's shameful to the individual. And then there are cognitive barriers in terms of, again, this specifically more frequent with our older adults in terms of not having the cognitive wherewithal because of memory decline or beginning cognitive impairment or dementia, as well as I'm sure there are other barriers too. So we need to go out into the community to outreach, and then we need to work hard at engaging our clients into services. So one of the models for community outreach that's specifically developed for older adults is the Gatekeeper model, developed by Ray Rauschko and Ellen Florio in Oregon. And in this model, our job as the service providers is to make relationships with people who know the day-to-day lives of older adults, people with whom the older adults feel comfortable with or are familiar with, and people with whom we can develop contact. So the model, the Gatekeeper model, includes recruiting gatekeepers, and these again are the people that have the greatest opportunities for interacting with older adults. It includes developing a procedure for taking referrals and also making referrals. It includes some kind of community response system, something to refer to. And then one of the things I think we learned this, and it probably one of the most important things in outreach and engagement is persistence. And that is one of the things that the developers of this model also mention. So 2 weeks ago at our last session, we put up this specific list, and so these are some of the gatekeepers that I had thought of 2 weeks ago, including hospital discharge planners, apartment managers, senior staff, police, adult protective service workers, and so on. We already went over this list the last time. And in the some of the things that you wrote in, some of the comments you wrote in, you added a number of important other people, including Area Agency on Aging service providers, the regional centers, volunteers, pharmacies or pharmacists, neighbors, family members, peers, or service extenders, and there's different names for peer helpers, conservators, or the public guardian, geriatric care managers. I was at a training yesterday, and a presenter was talking about beauticians, barbers, and so on. And these are people, again, these are all people that can have contact with older adults, but to make the best use of our efforts, we want these to be people that we know we can make relationships with, that have a relationship with the older adult, and that we can be in contact with. So some of these people are a little harder to get referrals from, and some of them are going to be more likely to pay off for us. So if you have any others that you want to, we're going to go back to the list that we were just looking at. If you have any others you want to add, you want to type them in. These are the two lists. I think you have them on your PowerPoint in front of you. So if you have any other ideas, we can kind of continue to develop a master list, which I think, you know, and we can continue to develop this list as a way to help all of us brainstorm. Darcy, are you seeing any comments about other people to add to this list of gatekeepers?
Yeah, we just got a couple of comments typed in. I see City Ride or Access paratransit drivers, and from, let's see, churches, from George Prescott, landlords are another one.
Yep. So churches and various houses of faith, definitely.
Gardeners is another one, and Meals on Wheels delivery people, code enforcement officials, animal service providers, and mailmen are all being mentioned.
Friendly visitors, I see. Okay, I will take all these comments and add it to the list so we can kind of develop a long list. But I just wanted to tell you about one project that we've worked on here at Heritage Clinic, which I have been involved with and enjoyed, which is when somebody just typed in, bankers, somebody's just adding too, the mailmen or the postal carriers, that one of the things that we've worked with here is developing what we call postal carrier alert. And I think many neighborhoods have this, and some it's kind of more challenging. But here in Pasadena, we developed a consortium of lay seniors, police department, the Pasadena Police Department, the Pasadena Senior Center, a senior case management agency here in Pasadena, Huntington Senior Care Network, our clinic, and the Postal Service. And wait, hold on, let me stay on this slide for a minute. And so we developed a representative from each of these groups met together, and we developed a protocol for postal carriers to follow when they noticed seniors or disabled people that are on their regular route, when they noticed that mail wasn't being picked up for 2 or 3 days. The protocol that we developed was that they would, the postal carrier would call the senior center. The senior center would then check their records of the people that had signed up, and if they hadn't been told of a vacation, if the senior had not told them that they were going to be on vacation or that they had gone to the hospital, the senior center would call the Pasadena Police Office, and the police department would send someone out to check on the welfare of the person. And in doing this, it both helped several seniors that were in difficult situations. But in terms of being a gatekeeper, the other thing that this did is it gave us the opportunity to go and talk to the postal carriers. So we went and did trainings with the postal carriers and asked them, in addition to if they found someone that seemed to be in trouble, what to do if they were worried about one of their older adults on their route, and gave them the phone number to refer them to the mental health agency. So what this shows is that developing the relationships with the gatekeepers is time intensive. It's not a simple, quick project. So when it says persistence is key in developing the relationship with the senior, persistence is also key in developing the relationship with the gatekeeper. So we need to creatively arrange and be very deliberate about meeting with, choosing a small handful of those gatekeepers to focus on and really develop meetings with those people, educating the gatekeepers as to what you can do for their older adult. If you're going to ask them to refer older adults to you, they need to feel like it's worth their time and effort and their use of their relationship with the older adult. So we want to try to clarify to the gatekeepers why them referring their older adults to us would be useful to the older adult. We want to educate the gatekeepers as to what signs to look for that might suggest that the older adult has mental illness. We want to educate the gatekeeper on how to contact our system. We want to make that as simple as possible. Just one phone number where someone answers the phone or calls the person back really, really fast. And then we want to educate the gatekeepers about how they can talk to their older adult about referring the elder to our program. So these are some of the signs you can suggest to the gatekeeper to look for. Significantly worsened appearance or grooming, smell or bruises, deterioration in the upkeep of the home or yard. This is particularly true for the Postal Service, who would see the person's home. Would be true for Meals on Wheels. It would be true for utility workers. Looking for significant change in the elder's usual interactions. Other changes, significant or abrupt changes in behavior, worsened memory, and indications that the elder might be seeing or hearing things that are not real. So that's just a few of the things you could suggest that the proposed gatekeepers look for. Establishing a simple, friendly intake process at your organization so it makes it easier for them to make the referral. And then this is sticky for mental health agencies, but I think it really helps this process if we can provide feedback to the referral source as to what happened to the older adult. That's not always possible, but if we can give some kind of information back to the referral source, they're more likely to keep working as a gatekeeper with us. So some other ideas on community outreach would be to work in senior centers or senior apartment buildings. One of my very first jobs years ago, I was an outstation clinician at a senior center, actually at 4 senior centers, and I spent one day a week at each of 4 senior centers in South Philadelphia, and I sat there and went around and chatted with people in the lobby of the senior center, and usually the staff had pointed out specific individuals that they wanted me to develop a relationship with, and that's the way I got to know some people that had psychotic disorders, depressive disorders, and so on. Another thing we can do at senior centers and senior apartment buildings is to organize healthy aging groups, and I have a list. Yeah, here's a list of when we develop a sort of a healthy aging group. Again, this is time intensive, but it's a way to reach out to people and help develop relationships with lay seniors who may be in need of our services. It usually doesn't work to come into a senior center and run a psychotherapy group or a depression group. Sometimes it could, but we found that running something that's more on healthy aging and using kind of topics that are a little more accessible is a little more likely to get seniors to come. So other outreach efforts would be to educate physicians. This is a little harder to do and it will take probably more time and effort to identify physicians who are open to talking with us and encouraging them to facilitate routine depression screenings and substance abuse screenings. I think this is more and more a part of the medical practice, but there's still a lot of physicians that don't do this, and potentially with our support, they would be willing to do that. And then another idea for community outreach is to work with Adult Protective Services and or your local police department to arrange to obtain referrals of elder crime victims. A lot of times, elder crime victims and elder abuse victims either have just had a traumatic event, which could be the beginning of a mental illness, or they may have been mentally ill already. And so that's another group of people we might want to target for community outreach. So I just wanted to take a minute or two for you. If you're in a group, you can talk about this, or if you're by yourself, just think about this for a minute. And of the lists that we have just talked about, why don't you think about one or two gatekeepers that you would like to put some effort into developing further relationships with. And I'm going to, while you do that, I'm just going to put, let's see if I can find the right slide here. Okay, there's one of the lists. And again, we've had a whole series of lists that we've added that Darcy was reading. Adult Day Health Centers was also recently added to our list. So just thinking, talk amongst yourself for just a minute. Which of these gatekeepers might you want to put some effort into developing ongoing relationships with, in addition to what you're already doing, because I know many of you are already doing this. And that's something you can kind of continue to think about. But now I want to shift to talking about clinical engagement. So, well, actually, maybe this would be a good time, Darcy, for us to take questions. Okay. Darcy, have there any questions come in that you want to read to me?
You know, I don't see any recent ones. I saw a suggestion by Martha Morgan that fitness centers that have silver sneakers programs could also be a source to develop a relationship with.
Okay.
And there may be some some other applications with that, the special programs. I can look down the list of hands really quickly and see if anybody's got a hand up and see if they'd like to make a comment. So you they may have left their hand up, so I'm going to come to April Waldo. April, I'm going to go ahead and unmute you. It may be possible that she just left it up from before.
Yeah, sorry.
Oh, no worries. Did you have something you wanted to add, or?
No.
Nope, I'm good.
No. Okay.
Okay.
Thanks. I actually was sort of cheating. I know that her mic works. So, okay, let's see. I see a hand for Brian Nance. But I don't know if that's left over from before as well. Brian, if you're trying to join the conversation, you're unmuted now. But I see that you've joined through your computer, so you may not have. Oh, there goes the hand. I'm going to go ahead and mute you again just on the off chance something wacky happens. And Cecilia, I saw you put your hand up. Cecilia? You are unmuted if you want to go ahead and ask a question or make a comment. I heard something.
Well, yeah.
There we go. I think the ones that we're having problems with seem to be the ones who signed in through your computer. If you go to that audio box and choose the telephone option, if that's available to you, if you can make the phone call, it might be the easiest way to go. And Joanne, I see. Oh, nope, Joanne whipped that hand down. She just had it up from before. It was flying down.
I see a question that says, what kind of confidentiality do we need to share information with gatekeepers? And I think that's a really good question. Do we need a release, or just because they are referring implies we can share any information? My take on that is that once an older adult becomes a client, that you do need a release of information from the client to talk to the referral source. So that the easiest way is to ask the older adult when you get the referral, is it okay if I let your postal carrier, if I let your social worker know that you've agreed to let me come see you? I think it's a little bit more of a gray area. If the older adult has not yet become a client, then you're not legally required to get a release of information. So if they haven't yet become an official mental health client, I think you're in a little more of a gray area, and you probably have to decide for yourself in your own agency, can you tell the referring source that you're beginning to make contact with the older adult? So I think in my agency, if we don't think it's going to harm the relationship building with the older adult and they have not yet become a client, we think it is okay to let the referral source know that we are working on it. But that's a really good question. Is there anything other hands we should try, Darcy, or should we just keep going at this point?
I think we ought to go ahead and keep going, and then I'll keep my eyes out for you.
Okay.
Anybody who wants to add.
So in terms of clinical engagement, once we have received the referral, the way I kind of think about the overall process of clinical engagement is the short-term goal is to make contact and develop a working relationship, create safety for the client. I don't mean safety in the relationship here, although we want that, but what I meant is help the older adult be safe and reduce crises. So kind of crisis intervention is often needed at the very front end. Secondly, we want to stabilize the living situation, build a support network, link them with needed services, and reduce mental illness. And in the long term, we want to alter unhealthy patterns. And I know this is sometimes a challenge in our system when we have lots of clients and lots we need to do with our clients. But in the sort of maybe ideal picture, we're trying to help people change so that they are able to avoid abuse or avoid ongoing homelessness or avoid premature institutionalization and conservatorship. So the initial contact, in our agency, we have the intake coordinator gathering information from the gatekeeper and then assigning the older adult to a clinical staff person. The staff person, when there's clinical engagement issues, when the client is seen to be ambivalent or reluctant to engage, we want a clinical person to be making the first contact. And one of the things we do is the clinical staff person will start by calling by telephone, and then if that doesn't work, we actually do encourage our clinicians or our case managers just to drop by to see the person. And sometimes our clients don't have phones, and so it has to be by dropping by. We make a determination at this point whether we want to say so-and-so referred you or not. Sometimes when we've been referred, the client's been referred to us maybe by Adult Protective Services or police. Sometimes there are situations where it would not be useful to say who referred us to the older adult. A lot of times the person referring does have a good relationship with the older adult, and so we do want to say, well, your postal carrier was concerned about you, or your Meals on Wheels volunteer was concerned about you. Usually that is a helpful thing. We usually try to use language, as I mentioned a couple weeks ago, softer language rather than mental health language about how we define ourselves. We want to listen carefully. That's probably the biggest part, is being a good listener. And then allowing the client to take the lead. And this is a point where we really want to be following the client, not pushing the client to share more than they're interested in sharing. And we need to be really using our clinical skills really well and noticing if either we're starting to ask questions or they might be starting to talk about things that are more threatening, and we want to move to safer topics. So sometimes we might be asking too probing of questions, but sometimes even when we're not asking questions, the client sometimes starts to get into threatening topics, and we need to try to sense if that's a difficulty for them and help them move away from it. With clients that have reality testing issues, delusions or hallucinations, I think it's really important not to challenge them, but to empathize with how they perceive reality. We're going to talk about this more later in the summer where we don't really I think it's really important not to agree with the person's delusions or hallucinations, but also to not challenge them, kind of walk a fine line there. We want to identify and try to understand and empathize with the older adult's feelings that are linked to their perceptions and misperceptions. And this is where we're doing a lot of rapport building, meeting an immediate need. I think bringing tacos or hamburgers, depending on what the client likes, talking with the elder about something they're interested in, taking a walk, playing cards, bringing other things. And I thought it might be interesting right now if you want to type in, what else, do you do in your outreach and engagement process? What are some of the things you bring to your clients? I know some people have talked about bringing water or a blanket or food or food vouchers. I'm just wondering what else some of your programs, dog treats, so there's interesting. So an older adult that obviously has a pet, maybe bringing some treats for their dog would be engaging for the client. So at this point, a pill box, so a way to organize their medications that can help them. Bus passes, another idea that can be very helpful. And bringing something that is useful to them helps the older adult to know that you're there for their whole person. A pill cutter, oh, that's an interesting thought. That you're there to help their whole person and you're interested in what they want or what they need, and you're there to work with them. So with particularly hesitant or ambivalent or suspicious clients, we want to very gradually increase contact. So we might start off with just walking up to them and saying hello, or just knocking on their door and talking to them for a minute or two. And then we might want to just come back another time and see if we can very gradually increase the contact. And this is again where persistence is key, as we said before. So if the client refuses services, the client is asked whether we can check in with him or her at some later time. So again, this is where we're persistent. We don't want to be pushy, but we want to be persistent. So the difference there, of course, is a fine line. But if the client says they don't want mental health services, or they don't want services, but they want us to come back, we take that as meaning that they're giving us permission to maintain and continue contact. If the client says they don't stop, and that's where we need to be listening to when they're refusing our services. So while we're making contact, we're assessing them in a discrete manner. We're not pulling out psychological tests, or we're not asking them directly about hallucinations and delusions, but we're trying to understand them in a discrete manner. We're listening for what they want, what they say they want, and also what we think they might be implying that they want. We're listening carefully for mental health needs, safety needs such as risk of harm to self or other, risk of elder abuse issues including self-neglect, basic needs including do they have food, do they have shelter, do they have adequate clothing, and then pressing medical needs. I think this is a tricky one in that many of our older adults have lots of medical needs. Some of them are more pressing and more likely to be life-threatening, and we wanting to know what kind of medical needs they have, both of a pressing nature and of a less pressing nature. And we're trying also to assess, are they cognitively able to take care of themselves? So these are some of the things that we're assessing, again, in a discrete kind of manner. We try not to, well, we don't like to jump to an intervention that would be scary or threatening or hurt the relationship, but there are certainly times where we find out about elder abuse and we need to call Adult Protective Services or the police if it's pressing. We do sometimes find out that the person is imminently suicidal and may need to 5150 them. We may find out that they're a danger to others and it's a Tarasoff situation. We might find out that there's an imminent threat of eviction, and where this is not legally required, we may decide to make some active advocacy. And we do sometimes find out about child abuse, even with our older adults. That is sometimes something we find out about when we're assessing the situation, and then we have to make a child abuse report. So the next step is linking them with something, and in doing this we want to be thinking about what the elder wants, what the elder needs, and what we're able to help them with. So sometimes what they want and need, much of the time we can help them with, but of course sometimes that there are things they need or want that we cannot help them with. So there's a variety of linkages that we make at this point. It might be a crisis response team, like a hospitalization, or the police if necessary. It might be further case management within our agency or in another agency. It could be shelters, permanent housing of very various sorts. Benefits establishment often comes up here, maybe utility bill assistance, food and meals, religious connections, medical treatment we often find, although that's often a longer term process of getting them hooked up with that. But a lot of times we're needing to help them get medically stable. They may be needing glasses or help with hearing, help with managing their money, help with managing their medications, being hooked up with transportation, substance abuse help, conservator, etc. So I'm just wondering if you want to add anything, typing in here, just before we go to over general questions. But what else would you add that you link people with at this point when you're just starting to engage? What do you find that you're needing to link them with? If you want to type anything else.
Actually, Leslie Rich had a question about hoarding. Did you want me to go ahead and unmic you, Leslie? If you wanted to talk about that issue, you're unmiked. I mean, you're unmuted.
Hi. Yeah, I'm wondering, like, at what point I have an issue with someone who is hoarding, and yet meeting their needs, and where can I don't want to have her, drop the rapport that I have started with her, and just, wondering what you would recommend for something like that.
When you said meeting her needs, do you mean she is meeting her basic needs?
Her basic needs. She is cooking for herself with small appliances rather than a stove.
Mm-hmm.
Using paper products rather than plates, normal plates and cups and stuff like that. She does have water running in her bathroom, stuff like that.
Mm-hmm. So it sounds like you're saying she's not self-neglecting, so it's not a point where you need to make a report to Adult Protective Services for self-neglect. It's bad, but it's not quite that bad.
Right. Yeah. I guess I'm wondering, like, at what point do you report, don't report, you know what I'm saying?
Well, in terms of what you're required to do to report, Adult Protective Services, if they're self-neglecting, which would mean that she's not meeting her basic needs, and so it sounds like she is.
Right.
It's very tricky. Is she at risk of being reported? Is there a code enforcement issue? Is the housing department saying that she's a fire hazard, or is it also not quite that bad?
Nothing has been officially given to her at this point.
Yeah.
So.
I mean, I think hoarding, a few of the comments that we got after the last session, I think hoarding would be, if we can do another session, I think hoarding would be the first one I'd like to do a whole webinar on.
I'll sign up for that.
There's a comment in the comment box here about a hoarding task force. I'm not sure where you are.
Yeah, Dan Eberhardt. Dan, perhaps I can go ahead and unmute him. And Dan, are you able to talk?
I am.
Hi. There you go. You're open if you'd like to add anything about the comments that you've added.
Here in South Orange County or Orange County, we have the Hoarding Task Force, the Task Force on Hoarding, and it's just, it meets once a month, the last Thursday of every month, and it's a really good place to go to, develop more resources and to have things ready to go for the client when you meet with them so that you are able to maintain rapport and at the same time begin a connection with their some kind of remedial action on their behalf if they're open to it.
Mm-hmm. So an idea would be if you could, where you are, if you could find some other people that are working with clients who are hoarding, if you could meet together with them once every couple months and brainstorm together. I think hoarding is a very difficult situation to intervene with. So if you don't have a task force immediately available to you, maybe you could just make one up and get a couple other people together and meet once in a while to brainstorm. But I think part two of what Dan is suggesting, that if you gradually, slowly make a relationship with this person and really focus on the rapport building for a long time, then I think you can gradually try to help them see that they could avoid worse things happening if they start to declutter. I mean, I know for some of our clients, it can be successful to help them decrease their clutter, but it takes a long time of rapport building, and that has to be primary before you start asking them to start organizing their things.
Yeah, and I think also key is the multidisciplinary, having different, people, code enforcement, having different people involved with the ways to approach, meeting as a team and deciding how to approach the client so that there's a positive outcome.
Mm-hmm. Yeah. So getting some other, in addition to mental health and older adult service providers, getting some other disciplines involved, like code enforcement.
Right.
If you have any professional organizers, they can help too.
Right.
Thanks, Dan, and thanks for the question.
You're welcome.
Darcy, do you see any other questions for the moment?
Yeah, I'm sorry if I can interrupt just for a logistical issue really quickly. We have two boxes into which you can type information, one of which is the questions box, which I'm monitoring for questions. I've been using the chat box for private comments to people if they don't, for instance, have their audio pins entered. And I think inadvertently a couple people have responded back to me in that box. It's fine. I can bring what they've said into the conversation, but I just want to let you know if you type into that questions box, then Dr. Yang can see your question as well, and or your comment as well. And so that's a good opportunity. So try to bounce back and forth between those two things. I know it's a little confusing, and I don't know. Oh, I'm sorry. Go ahead.
I was just going to say somebody is asking for or Leslie is asking for a phone or a website of the task force that Dan is referencing. Dan, if you could email me any contact information about the hoarding task force you're mentioning, then Darcy and I could send that out to everybody. Unless you have it on hand right now.
I'm sorry, I'll send Dan an email that will have and I'll CC you on it, so if he replies to all, it will come to both of us, and that way we can get that information, if that's cool, Dan.
Everybody.
I could do that.
Okay.
Thank you. I'm going to mute you back up. Thanks.
All right. So to kind of continue on with the clinical engagement, we're working to establish a working relationship with them, stabilizing crises, encouraging them to accept concrete help, facilitating maintenance of receiving help. So that really is talking about the relationship here. Trying to help them stay as independently living as possible, unless they really need to be moving to higher level of care, and then that would be the goal. Resolving any interference with safety. So that might mean helping them to decrease their hoarding. It might mean helping to move them out of an elder abuse situation. It might mean helping them to get a home instead of living on the streets. And then a sort of a later goal is encouraging them to accept formal mental health services. So I wanted to describe a client that we worked with. So I'm just kind of going to go over a little bit, and I wrote these notes down just for myself more than for to describe the case. But we were referred a fellow who was living on a corner in a makeshift tent in Los Angeles, and he had been panhandling to get his money. He had no benefits. He had been homeless for 18 years, and had been living on this particular corner for a couple of years. So we sent out a clinician to meet with him and offered him help in a kind of a general sense of help, and he refused the help. So our clinician went again, and again the older adult chatted and talked. He opened up a little bit more, but he didn't want formal help from us. So our clinician went a third time, and this time brought him a hamburger, and the clinician had asked him what he liked, and he had found out that a hamburger was from a particular place was something he liked. So the clinician was being persistent, and the older adult started to talk a little bit more. And we found out that he had some medications that he needed. So we helped him to get to a medical clinic and to refill some old prescriptions that he needed. So we were trying to meet something that the client wanted. And then on another contact, the clinician was helping this man with some of his belongings, and the clinician felt the need to put gloves on. And on the next visit, the older adult would not talk to the clinician. So while our clinician was trying to kind of provide for her own safety, the older adult found that offensive, and so that kind of ruined our relationship with the older adult. So we decided to send a different staff person who had a little bit more flexibility in terms of their own feeling about touching things that had bugs on them. But this was, just a different personality of a staff person. So this case manager helped the older adult to try to link to benefits. However, this older adult had no knowledge of where his birth certificate was, no social security card that he knew of. So this began the process of a long process of trying to establish benefits for him, which was very difficult. But we did have flex funds, so we were offering to help him offering to pay for him to rent a room. But he refused to go into a room. He really liked, or it seemed that he liked, living on the street. So the case manager made a number of visits to the older adult, and in doing so kind of picked up that the older adult had depression, had some intermittent explosive disorder, and maybe had some kind of a personality disorder. Again, the staff person went again and again to establish trust with a lot of persistence and patience. And at a certain point, while our staff person continued to visit, continued to bring food, including hamburgers and some other things, at one point the police cleaned up his corner, and at that point he became willing to move into a room. However, when we took him to see some rooms, he was really rejected quite a few of the rooms that we offered to him. But we finally found one that was in the neighborhood of where he had been set up his tent. But once he moved into the room, it wasn't so easy for him to panhandle, and he didn't have an income. So one of the things we needed to do was figure out how to help him with his need for money. So while he wanted us to give him money to make up for his lost panhandling money, we weren't sure if that was a good idea. And I think we kind of tried it a little bit, actually giving him some cash, and realized that that was not such a great idea. But then we started to to pay for his rent and to buy him grocery cards for the grocery store. And he did settle in to living in a single-room occupancy hotel, and was actually working consistently with, we introduced a clinician in addition to the case manager, and we were working with him, continued to be looking for benefits to get him established. But as happens sometimes with older adults, he had a stroke, and he had a significant stroke, and he was taken to the hospital, and then he was moved to a nursing facility. So this is kind of both an illustration of both the success in developing a relationship with him, but also what some of the frustration is with working with older adults. Sometimes we make a lot of progress, and then they have a medical issue that really changes things for the person. We continued to visit him in the nursing facility, but actually his condition deteriorated to a point where we no longer did that. So that's an example of an extended process of clinical outreach and engagement. I don't know if maybe just take a minute to see if there's any responses to that case presentation, either in writing or in by hand. Darcy, is there anybody that wants to make a comment about the case description?
Yeah, I see that Carla had commented in the questions box. I'm looking to see if she also has her hand up as well. She had mentioned that some of the homeless sell their medications to buy cigarettes and alcohol, and she was asking, did this particular panhandler have a co-occurring disorder that you're aware of?
Yes, I think so. Yes.
Yeah.
And I think she's probably, you know, he may have been selling medications. I don't know, but that's definitely a good possibility. But it did seem like he was using some street drugs.
And so probably self-medicating. Or I'm going to go ahead and cruise down and look for hands if anybody has something they would like to add into the conversation. I'm doing a quick glance through. Lori Sundholm, I see a hand there. I don't know if it's new or old. I'm going to go ahead and unmute you. Okay, Lori, you're mic'd if you have something to say. And Mary Alport and Mary, I don't know how to say your last name. I'm sorry, Hisai, I think both have had their hands up. I'm going to go ahead and try Mary Alport first. Mary, you're mic'd now if you have a comment. And Mary Hisai. Okay, those just must be old hands.
Okay.
Hand system isn't, and Paul Knight.
Well, we'll keep up with the writing the questions. There's one comment here from Lori Lark saying that it's a good presentation of meeting the client where he is, and yes, that's literally and figuratively. And I just thought it was interesting that different clinicians can meet different clients where they're at, and some are better able to meet certain clients where they're at, and some staff people are better able to meet other clients where they're at. So, you know, that's another thing in our programs that we need to kind of be aware of, you know, what are our staff's personalities and flexibilities like. So during, you know, our mental health interventions, a lot of what we're doing is active listening, relationship building, some of these linkages that we've already mentioned. We want to really be aware of where they're at with their social network and seeing what we can do to help improve and restore their social network when that's possible. I think we've already talked about that, so I'm going to move ahead a little bit. The goal of the engagement process is to transition the person to formal mental health services. I'm not sure if all of our programs are funded the same or not, but we want, I think one of the goals is when we can to transition them to where we can bill their Medi-Cal insurance, which in order to do that, they need to become an actual mental health patient or client. And so we want to be assessing their ambivalence and checking in with whether they are interested in mental health treatment. And we don't want to bring that up right at the beginning, but as we develop a relationship and they begin to trust us, and you'll notice I didn't use the word trust before. I was using the word working relationship because I think trust doesn't start at the beginning, and I'm kind of hesitant to use the word trust at all, but we do, once they do seem to have more of an actual trust in us, we have more of ability to ask them to enter into a formal mental health relationship with them. And at this point, we could ask them to sign the consent to treatment and then formally transition them over into mental health services. Again, we don't want to push. We want to give them the opportunity and be persistent, but we do end services if they actually are saying no. I'm going to just talk briefly about staff selection and staff supervision. I think the main thing with staff selection is relationally oriented people and people who are flexible is really important, as well as people that can be persistent in the face of rejection. I think many of us go into the helping fields because we like relationships with people, and yet in this type of work, we have to be able to be patient with clients saying no, they don't like us, or clients kind of refusing to go along with what we're asking them to do. And I think training in severely mentally ill or homeless people or so on, or people that are more ambivalent, in that we need to really the staff really needs to be supported in how to handle reluctant, hesitant clients, how to manage boundaries, how to attend to what the client is saying by their behavior, not just their words. And let's see here. And here on this, the second to last bullet point here, tolerating rejection in small successes. So having patience in a kind of slow, small steps. Okay, and then just kind of facing burnout. So since we just had questions and comments, I'm going to just mention field safety. In their handouts, I gave you a copy of the safety protocol that we use at my agency. And I think I think I'll come back to this if we have time, because I want to get into the boundary issues. And you have, really, this is all written on your handout in terms of some of the suggestions we have about how to assess for safety for our staff when we send them out to the field. But maybe one of the main issues on safety is to really train our staff and for staff to feel supported, that if they have safety issues or concerns, that they're not going to be denigrated for raising them with the supervisor, but to really empower the staff to be able to bring up safety concerns and then address them as best we can. So if we have time, we'll get back to that. Otherwise, just read the handout and we'll go from there. So what I want to talk about now is boundary issues. So one of the things that really seems to come up a lot when we take it comes up a lot in mental health services in the office or in the clinic. There are all kinds of boundary issues. Do you touch a client? Do you accept a gift from a client? Do you go overtime with a client? Do you drive a client somewhere? There are all kinds of boundary issues that come up. But when we go out into the field, the boundary issues are the clinician or the staff person is not in control of the environment. When a client comes into our clinic, we have some control. So many more unpredictable things happen. And I think that what that does is that puts a greater decision-making requirements on the staff person. So, for example, if you were in the clinic, you would walk out to the waiting room, and if your client and her daughter were sitting in the waiting room, you could have the choice of whether you wanted a family session or an individual session with the client. But when you go into the home and the client is sitting in the living room and the daughter pulls up a chair and joins the session, you don't have as much control at that point. So in the previous slide, I talked about kind of a usual approach to mental health treatment. Typically, I think the way we were trained in graduate school and so on was we listen to what the presenting problem is, we gather information, we make a diagnosis, we formulate the case, we try to understand why is the consumer or the client having these issues. We set goals, treatment goals or recovery goals. We establish a treatment plan, and then we try to follow the established treatment plan. And what I'm suggesting here is that it's still, when we do the in-home treatment and we follow the recovery model, it's still really important that we follow this same procedure, but then we bend things. We are flexible with it. But if we start off, or as soon as we get enough information, if we set up a diagnosis, an understanding of why the person is like she or he is, the goals, and a treatment plan, and try to follow that treatment plan, we'll have more of a map of how to address the issues that come up. So the issues that I want to go over today are clinical dilemmas, ethical dilemmas, legal issues, and safety and liability issues. So Again, my suggestion is that we follow a standard mental health or recovery approach as much as possible, going back to the previous slide. Then when we can't do a usual treatment approach, we want to see, well, what is happening so we can't just keep doing the usual mental health treatment as usual. And then we want to apply a flexible response. So when the daughter comes and sits down, we want to think flexibly and think about what's the most clinically beneficial in this moment, what is most ethical, is there anything legal or illegal, well, is there anything illegal here that we need to watch out for, and are there any safety or liability issues? And then always, whenever we have questions about our boundary issues, the more we can talk with others about it, I think the more we can get ourselves clear. So some of the clinical boundary dilemmas that we encounter when we're doing in-home or in-field work is the presence of significant others. So like I said, a family member might just come and plop down and join the session, or we might be walking up to the client's home and the neighbor comes by and says, well, who are you and what are you doing here? And again, we want to think about what is going to be clinically most beneficial. Is it going to be to include the daughter, or are we in a situation where it's really, we really need to get the information from the client herself? And my take on the presence of significant others usually is at the beginning, the first session or so, I often will talk to the client the way they present themselves, with or without their family, but then make it clear that on the second session or the third session that I need to talk with the client alone. And then after gathering information, deciding, should this be a family intervention or should this be an individual intervention? So another issue that comes up, I think, quite a bit is role challenges. Sometimes the client will ask us to do a simple thing like mail a letter for them. Sometimes they'll ask us to go to the bank and get money for them. Some of the time they'll ask us to go shopping for them. And I'm going to go back to the previous slide here just to remind us that when they ask us to do these things, it's not that we should do them or shouldn't do them. I think it's really important for us to think through what is of the most clinical benefit to them. And is there anything ethical or unethical we need to pay attention to, legal or safety? So when they ask us to go shopping for them, I think there's probably nothing ethical or unethical about going or not going, or legal, or necessarily safety issues, but what is clinically most beneficial? And one of the questions I would think of here is, what is most empowering? What does the client need, and what is the most empowering way to meet their need? I think sometimes we're tempted to do things for people that they could do themselves, and actually they might become more empowered and develop more strength and self-esteem if we don't do it, but then sometimes that's hard to say no. Let me see here. So in terms of role challenges, I think that, you know, an example I come up with is a intern that I was supervising came and met her client at home. The client was in a wheelchair and had in-home supportive services. However, when the clinician got to the home, the client was sitting in a wheelchair, had been sitting in the wheelchair since the day before, so for about 15 hours had been sitting in the wheelchair. Apparently the IHSS worker had not come in the evening to help her get into bed, had not come to feed her food, and although my clinician was there to do counseling, she realized that it was more ethical that she get the client food, that her going into the kitchen and preparing breakfast was more important than doing the therapy. And so what seemed most ethical was to change her role from being a therapist to being a helper and cooking breakfast for her. So let's see. We've been talking about presence of others. We've done that. So in terms of role challenges, I just kind of wanted to bring up another example. When we're in the clinic or in our office, we can sit kind of face-to-face in a more typical chair arrangement, but sometimes we get to our clients' homes. I thought this was just a funny picture. not that I've ever been in a client's home that had a chair like this, but we do sometimes have unusual seating arrangements that are offered to us. Sometimes we are asked to, or the only place to sit is on a couch next to the client, or perhaps on the bed next to the client. And so we want to try to think through what is going to work here and be flexible, but be, again, thinking about what's going to help the client most clinically, what's ethical and legal, and what is safe. So some of the things that can help us in setting the professional frame is to mentally remind ourselves that we're not a son or daughter, we're not a nephew or niece, we're not, unless, I mean, some of you listening may be friendly visitors, but for those of us that are professionals, to remember what we're here for. If we're here to do case management, we're here to do therapy, or whatever it is. Sometimes it can help us in how we dress. How we dress is defined by, determined, I'm sure, by a lot of issues, but sometimes kind of dressing a little more professionally can help set the professional frame. Sometimes it can help to have a ritual when we're coming in to do counseling, to start maybe by shaking hands and start hopefully by pulling chairs into a setting that might be more conducive to therapy and not in a setting kind of like where we're really close to each other side by side. Sometimes setting up a place to meet in a specific part of their home. And then we want to think about interruptions. Sometimes the client will have their television on. Sometimes the phone will ring. And what do? Do we let them make the interruption? Do we tell them they can't? Do we observe what they do and then make suggestions? There's a lot of different ways we can respond to interruptions. The kind of a suggestion I would have is the first time it happens to just observe it and see, kind of try to understand what it means to the person. Then consider suggesting that, now let's turn off the TV. How about if we turn off the TV this time? Or how about if the phone rings, you make a quick answer to the phone but don't talk for such a long time. And then it can get to the place where we might want to set limits with our client and say, for me to come, I only have, an hour to be here or 45 minutes, so we're going to need to not be answering the phone while I come. Or if you need to take a phone call, I'm going to need to leave. So it can come to where you need to set limits. But those are some of the things you want to be thinking about, some of the ways and interpreting might be, we might let them do the interruption, but then we might talk to them. For instance, I had a client that I was seeing who generally when the phone rang, she just let it go to the machine, but one time she picked it up and had a kind of lengthy conversation with someone on the phone, and when she hung up, I noticed that it seemed kind of different, and it may have been related to the topic. We had been talking about her son who had passed away when the phone rang, and it seemed like that maybe she had, either on purpose or not, had wanted a distraction from the difficult subject we were talking about.
Dr. Yang?
So, yes?
Hi, I was going to say we do have a couple of questions kind of compiling up, but there might be a better time to address them.
Yeah, go ahead. Go ahead.
There is a question from, from Dennis O'Connell talking about that one of the most challenging and clinical ethical issues is working with a client who definitely needs a higher level of care but refuses to do so. Mm-hmm. And he comments that the role changes 180 degrees from trying to maintain the client in their environment to advocating or working against the client's wishes. So he was saying specifically he would like to have guidelines for the decision-making process, and I could conceivably go ahead and see if your mic is working, Dennis, if there is something that you'd like to add to that. But on the other hand, Dr. Yang, if you wanted to address that.
Yeah, I'll just go ahead and address that. Yes, I totally agree that is a very difficult spot, and it does shift from us wanting to meet the client's wishes, wanting to keep them as independent as possible. But if for judgment issues or for cognitive capacity issues, the guidelines for decision making, that's something we could kind of think about. I mean, right now the guidelines that we have are is it a self-neglect or an elder abuse situation, or is it a 5150 situation? Are they cognitively incapable, and are we needing to refer them for conservatorship? I mean, those are the three areas that we think about. And it is very difficult, and it does change our relationship with the person. And I've had the experience where clients, when we have felt we needed to move towards conservatorship for the client, some clients moved across that shift with us and stayed in a relationship with us, and others just were too offended and too upset to stay being our client, and we were no longer able to have them as our client. So sometimes we have had to refer them for conservatorship or have them hospitalized, or had to refer them to APS for self-neglect or elder abuse. And so sometimes the client can negotiate that with us, and we can negotiate that with the client and stay in relationship, and sometimes not. But, you know, let me think about guidelines for that. That's tricky. I don't know if there's
And Dennis followed up with another comment agreeing. I don't know if he couldn't join us when I unmiked him, but he said that at some point we enter what he calls the gray zone, where it becomes increasingly risky for the client. Right. So he was in agreement on that as well.
Let me just comment on the gray zone, that that is one of the things probably any mental health provider has to do, but I think more so with older adults, because we are also dealing with decreasing cognitive capacity and decreasing medical, increasing medical problems. So I think we have to live in the gray zone with our clients more than is comfortable sometimes when they don't quite meet criteria for conservatorship or 5150 or self-neglect. So I think that is part of what we have to do, is live in the gray zone a little bit more. Anything else, Darcy?
Yes, Ana Argueta mentioned that another area in which staff need support is just due to the numerous deaths on their caseload due to the population that that we all work with in that area.
I'll address that when on another session when we're talking about death and dying. We'll come back to that. But yes, definitely.
And then specific to navigating boundaries, Heather Johnson mentioned, how do you go about navigating boundaries when you're both the case manager and the therapist? It's more difficult to differentiate the boundaries between the two when one person is fulfilling both the roles.
Yeah, I think that's true, and I think that a lot of our MHSA programs are, well, and maybe non-MHSA programs as well, but we are doing case management and doing counseling, and we're the same person. I think, again, I do think thinking about what is best for the client and what is ethical, what is legal, and what is safe are just some guidelines. But yeah, it is more tricky when let's say we drive the client to the doctor's appointment and it's an hour drive each way and you're their therapist. What do you talk about for all that time? And maybe you're waiting in the waiting room for another hour. It is definitely more tricky, and you're probably not doing psychotherapy for 3 full hours, but you're in a psychotherapeutic relationship, but you're also taking them to the doctor, or maybe even helping manage their money. Although I know in our agency, for a while we had case managers helping with money management and as their clinician. We decided that was just too difficult too flexible of a boundary, and we shifted it to where someone else in the agency does the money management than the case manager and counselor. But yes, it is more tricky, and I guess consulting is what we can do on those things. So I want to talk a little more of kind of another clinical dilemma that I think we have in-home work is when we're to the point of doing more debrief counseling, or maybe doing trauma debriefing, where we're actually doing more talking with the client about emotional issues. I think the pacing is difficult in home with frail seniors who are isolated. One of the things for therapists, we've been told one of the ideas when client comes to our clinic, if we talk about really emotionally evocative, emotionally difficult issues, we talk about it for the 50 minutes or 45 minutes the person's in our office, and then we can tell the client, well, we'll talk about it again next week. Try not to, obsess over it during the week. But if we're in their home and the environmental cues don't change for them, and they're pretty isolated and let's say they're bedbound or homebound, it's much more likely that their emotions are going to be harder for them to modulate. So I think it's really important that we really titrate how much we ask clients to talk about grief or trauma or really intense feelings. I think it's really important that we don't avoid it, but also that we maybe spend, and out of a 45-minute session, maybe we talk about introductory things for 10 or 15 minutes. We talk about the grief for 5 or 10 minutes, and then we talk about coping responses for another 15 or 20 minutes, and we just help them work through the grief in a very slow, gradual kind of way. And we carefully monitor how they're handling things. And one of the ways that I learned how to monitor things, I was working with a client who had been a victim of a violent crime in her home, and she was very anxious and very depressed, and I thought she really needed to work through some of her fear. After the break-in in her home, she moved from an independent housing to a senior apartment complex where she was not in danger of such a break-in, but she was having PTSD and depression. And so I thought she really needed to do some trauma work. And so I was encouraging her to talk about her feelings about the break-in. And at one point, she happened to tell me that she really dreaded the days I came to see her, which, of course, didn't make me feel very good. But it wasn't that she didn't like me coming, but the feelings that came up were really overwhelming. And I realized that I had not been monitoring her emotional responses as well as I should have been. So at that point, we came up with this idea of a treasure box, and we just kind of using visual imagery, we had her kind of hand over to me her feelings about this event, and we pretended to put it in a treasure box, and I pretended to take it with me. We did this sort of imagery idea, and that had some help. I think what was more helpful was the coping activities, to talk just a little bit about the trauma and then talk about her coping activities and help her think about what she would do to handle her emotions after I left. So other clinical things that come up are our feelings. I'm sorry, that's next. Transference, the client feelings. There are a variety of client feelings that come up. These are just some of them, but I think the transference or the kind of feelings that a client might have about us doing therapy in their home or counseling or case management is different than if they were coming to see us. I think there's a greater level of intimacy. They might think we're more like a friend or a relative. They may be more likely to bring up gifts or food. There's cultural nuances, particularly about the offers of gifts and food or coming into the home. Again, I was in a training yesterday, and people were talking about whether you should take your shoes off before you go into a client's home. And quite honestly, that's not something I had thought about before. And yet, in several cultures, it's inappropriate to walk into a person's home with your shoes on. Clients might feel it's intrusive. Erotic transference or sexual feelings might be aroused. So those are some of the client feelings that might come up. And then how do we feel going into clients' homes? We might enjoy it. I actually don't think I have that one on the list, and I should. But we might really enjoy going into their homes. We might enjoy getting the more information about the clients. We might enjoy the intimacy of it. But sometimes, too, we are more discomforted by what we see, or we might feel more overwhelmed or burdened when we see that their home is a hoarding situation, which we wouldn't have known about if they were coming to us. We might get more frustrated if we go out to their home and they no-show. If they no-show in the clinic, usually we have plenty of paperwork to take care of. But we might, I know I had a client that was a good 25-minute drive on the freeway, very far from here, and when she no-showed, and I couldn't count it for billing, it was rather frustrating. And even we might have the feeling of disgust sometimes, or physical discomfort in the situations we come up with. And you might think of what are some of the other kinds of feelings that you have as a staff person and or that you think the client might have because you're coming into their home. Maybe this would be another chance for you to type in some of your thoughts about other ways you might feel or other ways your client might feel, particularly related to being in the client's homes. Anybody have any thoughts about that? Or maybe I covered it fully. It looks like no other ideas. Okay, fine. So here are some thoughts about what to ask when you're trying to decide. Oh, here's a few things. Anxiety about MRSA, M-R-S-A. Yep. Okay. Here. Okay. Now we're getting a few comments about other feelings. Feelings, anxiety about rodents or the smell in the home or the temperature. Sometimes it's really, really hot, I would guessing, or really, really cold. So, yep, those things really make for challenges. And I think, we've mentioned hoarding a couple times today. I think in hoarding homes, sometimes the smell might be bad and the temperature might be bad and the rodents or the bugs might be bad. Stuff because of not enough air, the potential for health hazards in the home. So anxiety and discomfort with those. And again, that'll have to be a topic for another day, but those are definitely some of the feelings we might have. So I think for all of these boundary challenges, we want to be reminding ourselves, what is the treatment goal? Is the considered intervention, does what you're thinking of doing facilitate a treatment goal? So again, if the client asks you to go to the store for them, are you trying to develop rapport? Is the treatment goal developing rapport, so going to the grocery store might help treatment? Or have you already developed rapport and you're trying to get the client out of the house, so you're going to the store interferes with the treatment goal? So what are the potential clinical drawbacks? So, again, thinking about doing something for a client versus standing back and encouraging them to do it. And what is the most client empowering thing to do? Darcy, can we go to the poll about the key?
Sure.
I think this might be a good chance to think about that. I'm gonna go forward for a minute to a little. Okay. Let me describe this case scenario, and then we'll do the poll. But a client, not of mine, but a clinician I was supervising, had a client who was an older Latina female. She was bedbound. She had congestive heart failure. She had diabetes, a variety of other medical illnesses. She lived alone. She was never married, had no children. She had immigrated to Los Angeles quite a number of years ago, had lived in the United States for quite some time. She did have benefits. She had an IHSS worker who came every morning to set her up for the day, came every evening to get her ready for the night, left food out there for her for lunch, did have a phone right by her bedside so that if an emergency happened, she could call for help. At first, when our staff person went, she made an appointment with the IHSS worker to meet her and to let her into the house for appointments. However, over time, the IHSS worker's schedule became hectic and unreliable, and so our staff, hold on a second, our staff person would go and wait and not be able to get in. The door was locked, the client was in the bed, but the staff person couldn't get in. And while our staff person went several times and worked with the IHSS worker to try to get the IHSS worker to meet her there, the staff worker was starting to spend more and more time just waiting and not being able to get in. So a question, we talked about whether or not the staff person should accept a key to her apartment. So I'm wondering, do we have the poll there for that one? So here's a poll for you to answer. Would you accept a key to her apartment, yes or no? So so far the voting is leaning towards no, but we don't quite have everybody voted yet.
And I don't know if you saw that, Dr. Yang, but the no's voted faster. The no's were like, no, 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 and then the yeses started coming up.
Yeah. Okay, well, I'm not sure if everyone's going to vote, but right now what we have is 80% of you are saying no and 20% of you are saying yes. So I'm just going to go back. I'm going to put the screen back up to the case scenario. So it's interesting. I talked this over with my staff person, and in fact, and I asked her would she be comfortable taking the key, and she said yes. And I decided not to interfere with that. And so, in fact, she does have a key to this woman's home, and she is letting herself in. And in my decision-making of why I decided that I felt okay about that as the supervisor and as the clinical director of the agency, that this seemed to be a client who doesn't seem to be someone that, well, with any kind of characterological or personality disorder issues, doesn't seem to be the kind of, she's also not a person with any reality testing problems, so she's not likely to say the key was lost and someone else got in or become kind of paranoid and suspicious. And she also is not someone with significant cognitive impairment. She's probably got a little bit of cognitive impairment, but not a dementia. So she's also not likely to forget about what the decision was. And so we do have a key and we are going in, but I completely understand why more people, were saying no to this poll. It's
I'm sorry, Dr. Yang.
Yeah.
Sorry. Mark Odom actually wrote that they had that exact situation happen. They received a call today about a team visit that they had done where a colleague had a key to the apartment and they found the client deceased. Mm-hmm. The family filed a police report yesterday claiming the colleague had stolen valuables from the decedent.
Well, that's a really difficult situation, but thanks, Mark, for sharing that.
Yeah, Mark,
yeah. Wow.
If Mark has any additional information, if you want to go ahead and put your hand up, I don't know that I could unmic you, but it sounds like you pretty much gave us what you could do there.
Yeah, well, that's definitely a liability issue, and thanks for informing me of that. I'll have to rethink my decision, but we do run into these kind of situations where there was almost, we tried a number of different things to be able to get into her apartment without the key, and we didn't come up with any, but maybe that's something to think about, other kind of brainstorming for what we could do instead. I want to stop and check for a minute. Jacinta, I don't know if you're on the call. You were going to present a case. Darcy, can you see if Jacinta is attending today and if she's got her hand up?
Yeah, let me check that real quick and see where she is. Oh, no, I don't see her listed on the attendance.
She had offered to present a case, which is lovely, but then she also, her client was not able, we weren't able to get permission, and maybe she wasn't able to join us today. So I'll just kind of keep going, but just as a reminder, if any of you would like to, we would love to have one of you present a case. Next time, if you would like to, you can email me if you want to. One of my thoughts about guidelines for responding to gifts and food, I think, are much more frequently offered when we go in home. I mean, of course, in the clinic we can be offered food and gifts as well. But when I talk with clinicians, a lot of times people think, oh, we can't take gifts. But then when you're in the home and people are offering you things, it sort of changes the game quite a bit. So I kind of think it's important to think about where are you at in the relationship and what is the meaning of the offer of gifts or food. Sometimes accepting what's being offered really will enhance and maintain rapport, and I think it's important to do. I think if the gift is an expensive gift, it's probably important to not accept it. But if it's of a lower value, then I think we need to try to understand, why is the client offering us something? Is it because they feel like they have to offer us something to be good enough to receive our help? If so, then we might want to really talk about it with them. I think in any case, we probably most of the time want to talk about the meaning of the gift. I think sometimes we don't. I think with a client with a more psychotic disorder, we might just want to accept what they're giving us. But with a client that can analyze and evaluate the meaning of the gift, I think we want to kind of ask them, well, what are they trying to tell us by giving us this gift or offering us this food or drink? And then understanding whether it will help the treatment or not. If it's a food or a drink, you know, we want to think too about what we want to do, whether we want to put something like what they're offering us in our body. I think we want to think about the cultural issues. In some cultures, in my experience here in Pasadena, we're near Glendale, which is a very Armenian area, and refusing to take any food or drink, it can be considered offensive. And I think that's true in other cultures too, where saying no to an offer of a refreshment can be very hurtful. But on the other hand, we shouldn't have to put something in our body that we don't want. And one idea that has been suggested to me is, and I've tried this with some of my folks here, of saying, well, I would love that, but I just ate, I'll take it with me. Can I take, can we cut a piece and wrap it up and let me take it with me? And then, what you do with it after you leave is kind of up to you. Another thought about gifts that I have found to be helpful is to take the gift and hold it and talk about it rather than just refusing to hold it. And if it's wrapped, I would insist on unwrapping it with the client rather than taking a wrapped gift out of the home with me. Okay. Something that I think in our busy lives may not be possible, but when it is possible, I think it's really important to try to do kind of a case conceptualization and treatment plan. I think a lot of times we jump in and start trying to help our clients out of, what's urgent. We kind of do the most urgent thing and then the next urgent thing. But if we can take a step back, and sometimes the best way to do this is to do this within a treatment team or within a supervision session, to think about, kind of what those of us who were trained in mental health fields, when we were in graduate school, we were taught how to conceptualize a client's situation. And the third bullet here, thinking about our theory, the second bullet point, let's start here. The first one is just what's going on with the client. But the second one, theoretically speaking, according to CBT perspective, or according to an attachment perspective, or according to a psychodynamic perspective, how did the problems develop and what keeps them going? And then according to the same mental health theory, what would be expected, what would you hope to achieve with them? And then according to the same mental health theory, what would be steps towards these long-term goals and what would be immediate interventions? So to try to take a step back and think through what's really going on with this client, what would we hope to do in the long run, and what do we need to do right away? If we can do that, I think sometimes we can gain a little more coherence in our work. Okay, this is where we were going to do the client perception. So why don't we go ahead and take some more questions, and then if we still have a little time, I'll go back to the safety protocol. But why don't we see if there's any other written questions? Darcy, is there anything else to read?
Yeah, there's something I hadn't managed to flag a little earlier. Oh, Brenda Crawford left, darn it. She had asked if we had ever used trained mental health peer support recovery specialists when working with older adults.
In my agency, Brenda's maybe not there, but I'll go ahead and answer the question.
Yeah, sorry.
Might be interested. I think we have, and I think that is a great additional intervention to use peers who are trained as, we actually in our agency or in LA County we're calling them service extenders, but they're kind of basically peer counselors that can help as friendly visitors or outreach specialists or case managers, but they can have a certain kind of rapport with the client.
Okay, and there was a comment by Mark Odom earlier that Barbara Soniat, PhD MSW, has an excellent risk capacity model that deals specifically with when and when not to pursue actions or services with older adults who have self-neglecting behaviors.
Can you say the name again of the woman that has this, Barbara?
Yes, Barbara Soniat. I don't think I'm probably saying it correctly, but it's S as in Sam, O-N-I-A-T. Barbara Soniat.
We could write that down in an email for everyone and send that out.
Yep, I'll add that to some of the information that we're disseminating afterward.
Okay. So it looks like there's a question, common examples of interventions which interfere with treatment goals. So my thought about that, I mean, one would be doing something for a client that he could do for himself. So I think an example would be a client with, let's say, moderate medical issues or mild to moderate medical issues, and they ask us to drive them to the doctor, whereas we might be really tempted to drive them to the doctor if transportation is something we offer. However, we might rather, in a more empowering way, help them learn to use the paratransit that's available, or help them learn to have more patience with the paratransit, or maybe learn to use mindful techniques while they're waiting for the paratransit, or whatever. So if the client maybe could get themselves to the doctor themselves, I think it would be interfering with the treatment goal of establishing their own strength and self-esteem if we drive them. That's one example. Another example would be a client that I had who, when I came to visit her, she would always say, oh, I'm going to go make you some tea. And whereas part of me would say, oh, well, I should just go along with it. If I let her do that, it took about 15 minutes for her to make the tea, and then that really cut into our counseling session, which I think was interfering. It was kind of like she was wanting to distract. She wanted my company, but she was wanting to distract from the counseling, and that really cut into working on the treatment goals of, in this situation, it was grief therapy. That, you know, we were working on some grief therapy over lost life goals. She was in her late 80s, and she hadn't achieved some of the things she had wanted to, and so that interfered with the treatment goal. So those are a couple examples. I don't know if anybody else out there has some examples of that kind of thing, or there's any other questions.
Yeah, we had another question. This is from Sarah Bartlett. She had said, it's Sonia, by the way. I completely butchered that name for the previous information. Sarah Bartlett had mentioned, she said, what is your experience in mental health crisis intervention teams responding to situations where the crisis involves extreme agitation and psychotic symptoms in someone whose primary diagnosis is dementia? And she went on to say here they often won't respond since dementia is a physical illness and will suggest the ER, which is usually ineffective.
Yeah. You're describing it pretty well, and we get caught in this dilemma between dementia and mental illness, and yeah, I don't really have a great response to that. I think it's true that many of the mental health teams will not respond to a dementia issue. I think my best experience is trying to develop a relationship with the people on the crisis team and trying to talk with them about the fact that the psychosis is a mental health issue, even though the dementia is a medical issue. But that can be a losing battle, and sometimes we are left really having to deal with it only from a health perspective So, you know, we might end up having to call the police or the ambulance, the paramedics. That might be our only choice. But what you're describing is probably a difficult issue for many of us working in the older adult field across the state.
And Dr. Yang, if you'd like to see if anybody wants to try to speak in any longer length, I could try to unmic somebody rather than looking for hands, which hasn't been necessarily super effective. If somebody wants to type into the question box specifically, say I have a comment or I would like to talk, then we can look at that. And in the meantime, there have been a couple of comments. Lucy and Kai Pellin, I'm sorry, I know that's not the way your last name is pronounced, mentioned that the Alzheimer's Association may have different options and resources available for clients with dementia. Specifically, so that might be helpful. And then just to mention, we're at 5 minutes before the conclusion of the webinar, just so that you have that. If anybody did want to make a comment specifically on mic, if you want to type into the question box now, just say comment. I'll go ahead and mic you. Oh, come on, it can't just be us talking. Come on, guys.
Well, we're trying that. There's another comment from Mark Odom that the issue that was just brought about a dementia client is very difficult. Mark in Orange County says that their older adult crisis team will respond to dementia 5150s, but their adult crisis assessment team won't. So that sort of is potentially suggesting, I mean, many of our counties may not have an older adult crisis team, but it does suggest that the more over time, the more we can educate our crisis teams about the issues of dementia and the issues of co-occurring mental illness and dementia, we can hope that over time we could educate our crisis teams that there is a mental illness that's going along with the dementia that is within their bailiwick. But again, that's probably a process of advocacy. Okay, well, we've just got a couple minutes left. Oh, you know, there was one, you know, I'm going to try to go up a couple of slides because I wanted to call your attention in terms of talking about boundary issues. If you haven't heard of Ofer Zur, he is a psychologist that has a website that talks a lot about boundary issues, and I'm going to try to find my slide where I have a quote by him. And I wanted to point you to his website because he raises a lot of really interesting dual relationship issues. And as far as I know, he's not working solely with older adults or in-home work, but he raises lots of interesting boundary questions. And I'm on a listserv he sends, and it just raises really interesting questions. So if you want to go in and see if you can get added to his listserv, it might be kind of interesting. But he makes a distinction between boundary crossings and boundary violations. So he's talking about boundary violations occur when the therapist or the case manager crosses the line of decency and violates or exploits their client. Boundary crossing, he says, often involves clinically effective interventions, which could include self-disclosure, home visit, non-sexual touch, gifts, bartering, and other things. So dual relationships or multiple relationships or role challenges are not unethical or non-clinical or illegal, but he's helping us to try to think through what's a boundary crossing, which could be very much what you should do, and what's a boundary violation where we're exploiting the client or we're causing harm. So those are kind of another couple things to be thinking about. So I just wanted to remind you to please complete the exit evaluation. It will be really helpful. Darcy and I will try to, kind of go through those and see what you're suggesting for the next time. Our next webinar is on July 12th. We'll be talking about working with older adults from diverse cultural populations, Shirley Liao will be talking. And I guess that's about it for today. Anything else, Darcy, that you want to say?
Nope, just everybody, thank you very much. As we get this a little smoother each time, hopefully we can get, you know, more and more participation, but this is just such a really interested and engaged group. It's good to see. Thank you, everybody.
All right, we'll be talking in a couple weeks.
And Dr. Young, I'm going to let this scroll for another minute or two in case there are any parting comments anybody wants to write in the questions box. Anything else in the meantime, do look for that survey on the way out. Hopefully it will deploy, and if not, we'll get it straightened out. Thank you, everybody. Bye-bye.